to lead to you today. Sherry is the, I guess I'll call you a still newly appointed in fall of 13.
The first year.
Dean of the Wagner School, Robert F. Wagner Graduate School of Public Service. Sherry has an amazingly impressive and distinguished career. She served as Professor of Health Policy and Management at Columbia University's Mailman School of Public Health from 1998 to 2012. She took a little break in 2010 and just decided to be, or accepted an appointment as the U.S. Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services, the office fondly known as ASPE, for those of you who follow government offices, and a very important and influential office that's done a lot of creative discretionary work and research over the years, in the side of the HHS house that doesn't do that much research, as opposed to NIH, of course. So Sherry's been a fantastic government leader as well as academic leader. And previously, she served as Senior Economist for Healthcare and Labor Market Policy on the President's Council of Economic Advisors. That was from 92 to 93 under Bush and Clinton. And when she participated in Clinton's healthcare task force. I bet there's a lot of stories to tell there. But that's not the subject of tonight's talk. Sherry's been elected, just as a sign of her stature, to the Institute of Medicine of the National Academy of Sciences, the National Academy of Social Insurance, and the Board of Academy Health. And she's been a member of the Congressional Budget Office's panel of healthcare advisors. Her principal areas of research are health policy reform and mental health policy. That's what brought you here tonight, I know. Sherry holds a BA in economics from Yale, a master's in economics from Toronto, and a PhD in economics from Harvard. And I want to say that, you know, we're just getting to know each other as dean colleagues, but I have to say with a lot of enjoyment and admiration that I can tell you a couple things already about Sherry. One, she speaks her mind. Two, she's got a wonderful facility with humor, and she speaks her mind in an interesting and creative way, and I think has already made her mark as a highly respected and influential member of the so-called university leadership team. So, with no further ado, we're thrilled to have Sherry.
Well, thank you very much, Rebecca. It's actually a pleasure to have such wonderful colleagues here at NYU, and it's making learning deanship much easier and more pleasant. So thank you for inviting me to speak about the Affordable Care Act and the future of behavioral health care. And this is really kind of a fun talk for me because I get to combine what I used to be and what I was then. I guess not what I am now because I'm not going to talk about deaning. But a little bit about my research and about the work that I did in Washington and try and pull them together a little bit. And so I'm going to talk about the Affordable Care Act from the perspective that many of you know the book that I wrote with Richard Frank about Better But Not Well, about the tension between exceptionalist and mainstream policy in mental health. And I'm going to talk a little bit about healthcare reform and how people thought about behavioral health, and then talk a little bit about the Affordable Care Act. So this is a good time to be talking about mainstream and exceptionalist policy because it's actually the 50th anniversary. It's actually 51 years. I didn't realize this because the celebrations were last fall, but February 5th, 1963, President John F. Kennedy gave his famous speech about his ambitious agenda for mental health and mental retardation, to move people into the community, to emphasize prevention, all of these wonderful focused efforts to improve the well-being of this extremely vulnerable population. And in the wake of President Kennedy's speech for the last 50 years, and for most of the time before that, there has been a large body of work in mental health policy that has really focused on how we build organizations and institutions around taking care of people, around mental health care, and how we advocate for better mental health policies for people. But there is another side of thinking about mental health policy, and maybe the easiest way to show it is this slide, which just looks at deinstitutionalization. So everybody has seen slides like this. This is the number of people in mental health, in psychiatric hospitals in the United States. And what you see there is that in 1955, this number peaked. I'm not sure it actually has anything to do with antipsychotic drugs. I pulled this from somebody else's slides. But whatever. That was there, blocked the nerve there because I was looking for it. But the thing is that Kennedy makes a speech in 1963 in the midst of all of this, and little bits of things happen, and then institutionalization falls off a precipice. And it's not because of any of the things that Kennedy was speaking about. It's basically because, oops, well, that'll do. It's basically because of the introduction of the Medicaid program, which gave states enormous incentives to move people out of psychiatric facilities into other kinds of institutions like nursing homes or out of the hospital altogether. And what's interesting about it, let me just go back. What's interesting about it is that Medicaid was actually designed explicitly to leave mental health out of it. That's why this happened, because Medicaid didn't cover services provided in psychiatric hospitals. They didn't want to be about mental health. And yet, because of that proviso, it turned out to have this enormous influence on what happened to mental health policy because of Medicaid. And that kind of change around financing continued actually right almost to the present, which is we've really moved from a system in which mental health care was financed largely by state funds, state grant funds, and federal grant funds that were not tied to individuals, to an insurance-based system. So you can see by 1971, insurance, public and private, paying about a third of expenses, and by 2001, while the state and other federal share remained virtually constant, insurance component of financing jumping to about half of all expenses. So this growth in the way that healthcare is financed, mental health care is financed, has really changed the way the system works, the kind of care people get, by whom they get care, and so on. Really radical change in the healthcare system. So in our book, Better But Not Well, Richard Frank and I took on the question of looking at what happened over this period and how the well-being of people with mental illness had changed. The big innovation in the book, I hadn't really remembered until I started to look at it, is that we decided to look at this from a population perspective. To say, look, one thing that we know is that fundamentally the epidemiology of mental illness, there's not a lot of evidence that that has changed very much over time. Roughly a quarter of the population, somewhere between a quarter and 30%, manifest a diagnostic criteria for an illness at a point in time. That really hasn't changed. And about somewhere between 1.5% and 2%, we could argue, of the population has a serious and persistent mental illness. And that number has also not changed over time. So we can think of this as a defined population and start asking questions about where are they, what happened to them, by using this kind of denominator approach. And that's what we do in the book, and try and figure out what happened to people with mental illness. And our basic conclusion in the book is the title, People Are Better Off But Not Well. And I want to just start off with the first caveat, which is that we say, look, it's not because treatment got better. Actually, if you look at the history of mental health treatment, most of the treatments that were in use by the early 1970s were, according to clinical trial data, as effective as anything we have on hand today. So we have not had, as we've had in much about the rest of healthcare, revolutions in treatment. It's not revolutions in treatment that have changed the well-being of mental illness, of people with mental illness. So what has it been? So one thing that has really changed, and this is brought about largely by this expansion of insurance-based funding, is that many more people report mental health treatment. Far more people are getting care today than used to in the past. People talk nostalgically about the golden days of psychotherapy, but most of that was happening on the island of Manhattan, which was the only place that had anybody who did psychotherapy. There is the rest of the country out there. I think we have a statistic in the book, I'm going to try and remember it. It's something like half of all the psychiatrists in America were in Manhattan. So you can see that there's been improvement in the percentage of people who got treatment, the percentage of people with a disorder who got treatment, and even the percentage of people with a serious mental illness who got treatment. This is another thing that people sort of imagine, a world in which everyone was getting treatment back in the 1950s, but that is just not the case. And if you want to look at this, there's also sort of the sobering feature of this, which is the not well part. Even today, or 2001, only 40% of people with a serious and persistent mental illness were getting treatment at a point in time. So there's a lot missing in this picture. But there's been a pretty steady gain in terms of people getting treatment. And not only are they getting treatment, but there's a fair amount of evidence that suggests that the quality of care has improved. That people who are getting treatment that is more likely to be working for them. This is care for schizophrenia. Here's anxiety disorders. We used to treat anxiety disorders with benzodiazepines, which are not a good thing to be using. I don't know any of this. Howard Goldman taught me whatever I know. Now people are receiving more effective medications. More people with bipolar disorders who are getting psychotherapy are getting a higher intensity of psychotherapy. So we're doing better in terms of treatment for a variety of conditions. And part of that is the dissemination of effective treatments. One of the other things that we point out, actually, I like this, so I'm just going to show it to you, is what we call exnovation, which turns out to be really important in mental health. These are really hard disorders to treat, and so we wind up trying things, and some of them are pretty brutal, and then over time we stop doing them. So part of the reason that people are doing better is because we no longer subject them to insulin shock therapy and hand out tranquilizers. So people doing better, getting better therapy. So that's number one. Number two, people better protected against financial risk. Expanded coverage has led to a decline in the out-of-pocket share of expenses for people with a diagnosis. And that's really important because especially for people with a severe diagnosis, and most especially for families with a child who has a severe diagnosis, the out-of-pocket costs of mental health have been truly catastrophic in many, many cases. So we see real improvements as health insurance-based financing moves to reductions in out-of-pocket share. So what's the move to insurance meant? It's meant more people have access to care, more people have better financial protection, and people have more choices in where they get care. One of the things about the grant-funded system is that the choices were really in the hands of the suppliers, not really so much in the hands of the consumers. Now you have an insurance-based system, you have a lot more choice from the perspective of the consumers. So all of that is well and good, and we didn't get too much flack for that. But we made another claim in the book, which was that people's living conditions had also improved. And I want to just go through that for a second as well. We looked at the resources that were available to people with mental illness. And again, what you see is that mainstream programs, expansions of programs that were not intended, not designed for people with mental illness at all, have really made a substantial difference to the well-being of people, especially those with severe mental illness. So the fraction receiving food stamps has gone up. And we do this by kind of, reverse Bayes law. We know of food stamp recipients what fraction have a serious mental illness, so we can back out what fraction of people with a serious mental illness are getting food stamps, right? A third of people receiving Medicaid, now nearly 2/3. No SSI in 1971, 72, 40% receiving SSI. SSDI also rising. No Section 8 housing vouchers. So you can really see that, especially with SSI and SSDI, this tremendous growth in the availability of income support outside of the hospital. And if you think back to Kennedy's plea for getting people into the community, having community-based mental health centers was a very important thing to get people out of institutions, but they needed a roof over their heads. They needed a way to get food on the table. Until you put these resources in people's way, you really couldn't effectively have a policy of moving people into the community. So these things have really changed, and as we showed, what this has led to is an improvement in the number of people who are living independently or with their families. Back in 1970, nearly a quarter of people with serious mental illness were institutionalized in psychiatric hospitals or similar facilities, and about 72% even then lived with their families. People sometimes talk about the days of institutionalization as though everybody with a serious and persistent mental illness was locked up. That is a completely absurd claim. There were never enough people in psychiatric hospitals to match the proportion of the population with these illnesses. So even back in 1970, 70% or so of people were living with their families. That number has actually gone up to 84% today. So lots of people living in the community. Now, it's important to know, mainstream policy has been really important. It's gotten people SSI, it's gotten people Medicaid, it's gotten people choices in care. It's all great, but mainstream policy that has buffeted the mentally ill in a good way has also buffeted the mentally ill in a bad way in some cases. And here, the most striking example of this is the rise in incarceration. So the United States has decided around 1980, and other people know about this much better than I, to start imprisoning a lot more people, and that caught up a lot of people with mental illness. So we actually see big increases in the proportion of people with mental illness who are incarcerated. There is a school of thought that thinks the direction of causality goes the other way. You can ask me about it later, but I'm pretty persuaded that it goes in this direction. So more people are homeless or incarcerated among the people who are seriously mentally ill. We estimate that in 1970, about 2% of the population were homeless or incarcerated, and today it's more like 7%. So again, people are doing better, but there's lots of room for improvement. So let me just recap before I go on to sort of the body where I want to go, which is what we've learned from looking backwards is that mainstream policy changes really matter to people with mental illness, whether serious or just the less serious mental illnesses. That changes in mainstream policy, in mainstream health policy, in mainstream social welfare policy, have had tremendous effects on the well-being of this population. Far greater effects than anything that happened in what I would call exceptionalist policy. So we've had a lot of policy that aimed at people, aimed directly with a laser eye at people with mental illness. Those policies have been very important for the population to touch, but typically they don't touch anywhere near the number of people that the mainstream policies do. So we have sort of exquisite, gem-like, beautiful, exceptionalist policies, but they only touch a very small fraction of the population. These policies really go and hit a lot of people. And their effects on the lives of people with mental illness have been largely unanticipated. The people who were passing Medicaid were not thinking about the mentally ill. They were not thinking about the mentally ill, even in thinking about SSI, surely not food stamps. So these are quite unanticipated changes. Now, from a federal perspective, if I'm thinking about mainstream social welfare policy, the story almost ends in the early 1970s. We kind of stopped doing it. There's TANF, the change in welfare in the Clinton administration, but that did not have a huge impact on the population with mental illness because it was mostly moms and kids. So we haven't had very much since then, but there have been efforts. And so mainstream health reform between 1970 and 2011 did think somewhat about mental health policy. President Nixon and President Clinton both put forward comprehensive health care bills, and since then we've also had parity. So before we look at the Affordable Care Act, it's worth looking at how mainstream health policy thought about mental illness coming up to this. And so the Nixon plan, Richard Nixon put his health plan forward in 1974. It actually looked an awful lot like the Affordable Care Act in many dimensions. The next thing that happened was Watergate, so we didn't get there, but that and several other things. But he actually had a mental health benefit. It was 30 days of mental hospitalization and outpatient benefits defined as the dollar amount sufficient to pay for 30 visits to a private practitioner that could be used to obtain services in comprehensive community care settings. Or if you decided to go see a private doctor, you could get 15 visits. So it was a pretty elaborate and complicated design, and I thought you might appreciate this exchange between Senator Bob Dole and Cap Weinberger as he was talking about it. Does that include psychiatrists? Yes, I am told even psychologists are covered. Senator Dole, psychologists? Because of mental health coverage, psychologists and mental health therapists and psychiatric social workers could be reimbursed for services rendered under the auspices of comprehensive healthcare centers that would ultimately be under the direction of the doctor. So, right? So, but by 1974, you really have the thought that in this mainstream health, I mean, I don't want to, it's easy to poke fun at Richard Nixon, right? But we don't have him to kick around anymore. So instead, I think it is important to realize that by 1974, the idea that if you were going to do comprehensive national health reform, mental health had to be in it, was a pretty audacious idea, even if you don't like the way that the benefit worked. So here's the Clinton plan, and actually, lots of people that you probably know worked on the Clinton plan, even on the mental health parts of it. So after the failure of the Nixon reform, 20 years passed, Bill Clinton starts to work on this, and he has a team of mental health policy researchers. He comes up with a plan that is somewhat more generous than the Nixon plan, but it's not really that generous. It's pretty far from equal. And you can see it's 30-day inpatient limit, an aggregate annual limit of 30 days in residential services, 30 visits for psychotherapy, and some playing of games with the inpatient benefit and the outpatient benefit. It's a pretty circumscribed mental health benefit in the Clinton plan as well. Now, a lot of mental health advocates had worked on the Clinton plan, and they were really disappointed with the way that this had come out. So they actually left this experience and did about 15 years of research on how you could build a better mental health benefit. And out of that really came the Federal Parity Law and MPIA, the Mental Health Parity and Addiction, the Domenici-Wellstone Act, which argued that a well-designed insurance plan could provide parity mental health benefits without going up the cost. I should say social workers are one of the heroes of MPIA. That's part of the reason that you could do it, is because you can actually provide services. You don't have to use psychiatrists. You can use services provided by social workers who provide as I tell my psychiatrist friends, equally good services at lower cost. They don't like me for that, but I told them that if they don't like it, they should prove it, and they haven't done it yet. So this was actually a really important outcome, not only because it was important in itself, but it really allowed the Affordable Care Act to look at mental health in a completely different way. If MAPIA had not happened, it would have been enough perhaps to actually break the Affordable Care Act. It would have been very hard. One cannot imagine how the coalition would have worked out if you had to try and incorporate parity anew into the law. But because it had already happened, the cool thing about it is the Affordable Care Act hardly mentions behavioral health at all. It's hardly in there. The Clinton plan had an entire chapter on mental health, and the Affordable Care Act has like a few words scattered here and there with some demo projects and little things like that. But in the body of it, very, very little. The only really important mention is that essential health benefits, which all plans are required to cover, include mental health and substance abuse services. It's just one line right after maternity and before prescription drugs. It's not. There's no attention to it. It's not important. And it says parity applies to qualified health plans in the same way as MAPIA. So you've already done parity. We take parity, and that's it. So it didn't have to be an argument about it. There was no discussion. It was a completely neutral sort of non-event. A few other references around home and community-based services and so on, but really, you would almost read it thinking there was no such thing as behavioral health services. So, for those of us who were around, had worked on healthcare reform for a long time, the most amazing thing about the Affordable Care Act is that it passed. But from a behavioral health perspective, I think the most amazing thing about it is this is almost the ultimate mainstream policy. It doesn't even think about behavioral health, right? And yet, its effects are likely to be pretty enormous. So you can see how I got to where I am. Okay, so I'm going to talk about just 3 elements of the law, because even though I talk fast, I don't want to go on forever. And I'm going to talk about the insurance reforms, which people haven't thought about a lot, coverage expansions and the content of coverage, and delivery system reforms, and just a little bit on each one of them. So the most popular element in the Affordable Care Act, the one thing that Republicans and Democrats agree on, and the public agrees on in polling and everything, are the insurance reforms, which try and get those big, nasty insurance companies to stop treating people wrong. And it has gets rid of risk rating, gets rid of pre-existing conditions, limits the amount to which you can charge older people more than younger people, and so on. So now, here in New York State, this is not so important because here in New York State, we already have community rating in private health insurance. But that is emphatically not the case in the rest of the country. And these provisions have quite a lot of potential impact on people with mental health problems. And to see that, I don't know if you can read this, but this is actually out of, I just pulled a random underwriting brochure off the web. You could find any other one, and it was not special. This is, what is the risk classification if somebody applies for individual insurance and they have anxiety or depression? So they're over age 18, they're stable on a single psychotropic med, right? And they're no suicide attempts, they've never been hospitalized. You just have anxiety and you're taking meds for the anxiety. That's enough if you're between 23 and 29 years old for a 50% up rating in your premium. You pay 50% more in your premium because you have anxiety disorder. And if you're 12 to 18 and you have one of these things, you could be denied coverage altogether. It's sufficient for a coverage denial. So when you talk about pre-existing conditions, you think about people with horrible mega diseases. This is a pretty garden variety thing. Somebody with anxiety disorder who's taking meds and stable on meds. In early 2000s, a couple of researchers at Georgetown did this really cool study where they mailed applications for health insurance to 60 different health insurers around the country to see what happened to these cases. So they sent them a case and they filled in a form as if they were this person. And one of their cases was Emily, who is a 56-year-old widow who is situationally depressed. So that means depressed because of life circumstances, right? Out of the 60 offers, 14 of the companies refused to cover her altogether. The only thing that was wrong with her was that she was depressed. And she only got 9 completely clean offers, which means 9 offers that did not take into account her depression out of the 60. And 23 of the offers said, you can have coverage, but it can't cover mental health care. Most of the offers were at a premium surcharge. So this is like a real application. They were trying to figure out what's really going on. When we talk about pre-existing conditions, which are very prevalent, if you think about the prevalence of mental health disorders in the general population, especially people who might get treated for them, you can see that that's a very substantial share of people who have pre-existing conditions. Now, one way to think about this is, isn't it wonderful that people who have depression and anxiety will be able to finally get health insurance coverage? And that's definitely a fantastic thing. But the other piece of it is, this also means that if you are a person who is in the non-group or small group health insurance markets, that is, you run your own business, you're a professional, you're self-employed, you run a small business, and you have depression or anxiety, you can go and seek care. Because until now, it wasn't a question of your having insurance, it was a question of if you went and sought care, you might never be able to get insurance. So on the one hand, this means that people who already have care can have coverage, who are getting care can get coverage, but it also means that people who want coverage can get care. And I think in the case of things like depression and anxiety disorders, this is actually an important factor. People who have avoided, and we've talked about this a lot in terms of stigma. We talk about it as the stigma in mental health care, but sometimes stigma is a real thing. It's not only a psychological, it's always a real thing, but it's not only a psychological construct, but it has true financial implications in the world because you're going to get turned down for health insurance coverage. And so this is a situation where actually policy can remove stigma without affecting what we think about it. So the insurance reforms are a big piece. Second piece, of course, the biggest piece, the coverage expansions, and with it, the content of the coverage. So people with mental illness benefit from the fact that we are now expanding Medicaid, at least in the places that we're expanding Medicaid, to 133% of the poverty line. And I'm going to show you in a minute, the key point there is that expansion of Medicaid covers childless adults. And I will come back to that in a second. And then the health insurance exchanges and the tax credits, and of course the employer mandate and the individual mandate and all of that fun stuff. But here's the thing. If you look at state coverage standards for Medicaid before passage of the Affordable Care Act, what you would see is that in very few states, vanishingly few states, was anybody, a single man without children, eligible for Medicaid no matter what. So if you were just, or even a single woman without children. So we think about, poor people getting Medicaid, but poor people getting Medicaid only means poor women and poor kids getting Medicaid. It never really meant poor single adults getting Medicaid. Now, think about the population of people who are living, just think about a single man, it's probably the easiest way to think about it, living on 133% of poverty, living at 100% of poverty. 100% of poverty is less than full-time work at the minimum wage. Think about that population and what their mental health status is likely to be. This is a population that has a very disproportionate share of people who have mental health problems and substance use problems. It's a population, we already know that women in this population from other research have high rates of depression. So this is a population that is in considerable need of mental health services. It's not people who are sick enough to qualify for SSI. So they're not people who necessarily could meet the criteria for SSI, or maybe they haven't successfully met the criteria for SSI, but it is people who have fairly substantial mental health problems going through life and living in this way. So an enormous potential for the coverage expansions to matter for them. And if you look at what is likely to happen, wow, I don't understand why the slide colors don't match, but the red block are the uninsured. There's going to be if you look at people with mental health and substance use problems, there is an expectation of a very substantial reduction of our uninsured, mostly through the Medicaid expansions. So the places who are not doing the Medicaid expansions, this is not going to happen. And a big piece of that has to do with mental health and substance use disorder. But even among states, given the states that are not expanding, the Congressional Budget Office estimates that about 13 million people will gain Medicaid by 2016. And a rough estimate is that about 30% of them have a mental health problem or a substance use disorder. So this is an enormous expansion of insurance coverage to this population. And also a big increase in private insurance and in Medicaid. One of the populations, and the New York Times had a piece about it this morning, that is very much affected by this are people who are in jails and prisons or coming out of jails and prisons. And there is tremendous potential which we don't know how to tackle, I should say, because we have a bunch of researchers and doctoral students in the room, and I would say the literature on this, we actually did some work on it at ASPE, suggests that just giving people Medicaid is by no means enough to make sure that they continue to have services when they're discharged from jail or prison. On the other hand, giving them Medicaid means that perhaps somebody will find them an attractive target, which they certainly were not if they had no way to pay for their care. So we need to build the delivery system that responds to the availability of this coverage. We don't have that delivery system yet, but it is definitely a population that we can reach and we can do better with. I should also say, in sort of better but not well way, even after the implementation of the coverage expansions, the best estimate is that 15% of non-elderly adults with mental health and substance use disorders will still be uninsured for all or part of the year. So that's over 4 million people. We're still in better but not well. We're not going to get everybody. So one good thing is lots of people going to get coverage. The second thing is, what coverage are they getting? Universal coverage plus the essential health benefits. The coverage includes mental health benefits, so all of the plans must include mental health. I'll show you a picture of that in a minute. And the benefits are at parity. So it's not just that people are getting coverage, it's that they're getting, at least from a financial comprehensiveness perspective, pretty good coverage. So this is much better coverage than the Clinton or Nixon plans put forward. And this is a very confusing chart, but maybe you can read it. I'm going to start in the second bottom column, because the second bottom row would make the most sense. If by about 2016, about 25 million people will gain coverage through the Affordable Care Act, and that coverage will include mental health, substance use disorders, or both. This part of this work. But you see the 25 million? Everybody see the 25 million? Okay. The lines above that are sort of two different populations we don't think about very much. The 3.9 million in individual plans and 1.2 million in small group plans right now it's already over, but 3 months ago, who had health insurance, but their coverage did not include mental health or substance use benefits. Often substance use benefits, which were often not included in individual insurance plans at all. Mental health benefits sometimes. So about 5 million people who've always had coverage, that coverage will now be broader and will include mental health and substance use. When you heard all those people complaining about how their plans were canceled and men were being forced to buy maternity coverage, yes, men were being forced to buy maternity coverage. In my view, they were all born to women, but I tried that. It didn't go so well. Maybe you didn't need mental health coverage, Senator, but your mom did. Maternity coverage. But anyway, I don't know. Seemed like a good answer to me. But about 5 million of them, what they were missing was behavioral health coverage, which people, I think saying I don't need mental health coverage is less attractive than saying I don't need treatment coverage, because you might need it at some point in your life. And then there are about 30 million people in those markets who had a mental health or substance use benefit in their coverage, but it was not a parity benefit. So there's about 30 million people who will gain access to a parity benefit from having a benefit that was not at parity. So in total, about 60 million people whose benefits will be enhanced, either by getting new coverage or by getting coverage that has better mental health and substance use benefits in it one way or another. And the final piece of this is that, at least for the plans in the exchanges, for the commercial plans participating in the Affordable Care Act, they need to be accredited, and the measures that are required for accreditation include several measures of mental health, particularly this one, which is follow-up after hospitalization for mental illness. So there are network standards and accreditation standards. It remains to be seen how they will be used. We haven't seen the rounds of litigation about the network adequacy and so on, but it's there in the law, so there is definitely a framework built to be able to ensure that people are not only getting access financially to coverage, but that there are actually providers there to see them, and providers who are being held to some standards. Now, I actually want to digress for a moment and just talk about why this is important. And I don't know how much you've seen about the Oregon Medicaid lottery, but this is my favorite piece of information in mental health, and I get really annoyed with people who misinterpret the Oregon Medicaid lottery. But in Oregon, the state ran out of money for its Medicaid program, this is the short answer, and they decided to give people Medicaid benefits by lottery. So some researchers heard this on the radio, and they essentially used this as a randomized experiment in Medicaid, which you could never get through an IRB. obviously. But because Oregon was already doing it, they just had to piggyback. So this is a randomized experiment of the effect of Medicaid. The first unbelievable thing about it is, these are people who applied for Medicaid in Oregon. More than half of them tested positive on a screener for depression. So this is a very highly vulnerable population. And they were reported before the Medicaid expansion an average of 18 days a month in good mental health, which is not great. So if you look at what happens with a proper intent to treat design, the randomized design, you see a 55% increase in visits, a 50% increase in production in prescriptions, but a 10% reduction in depression, translating into 2 additional days a month in good mental health. So this is an enormous effect. This is an effect that in a clinical trial you would go, your stock price would go up a lot. So if you thought of this as a clinical trial of the effect of just giving people insurance coverage, it has an enormous impact. Much of the impact happens right away, which I think is really interesting too, and it should, if you're interested in what it means to be depressed, which the whole philosophy of all of this, it's not only that people got treatment, it's also that knowing that you can get treatment is really good for your mental health. And I don't think that should be shocking to anyone who's ever been sick in their lives. So we are about to provide a lot of people with Medicaid, and if it has this much effect, that would be pretty astonishing. So we will be providing people with a lot more care. A lot of it will be in primary care settings. A lot of it will be the people with serious mental illness through the Medicaid program, including people who have been incarcerated. We're going to figure out how to serve that population. So the third chunk of things I want to talk about is the delivery system reform. This makes the Affordable Care Act quite different from most of the previous efforts at health reform. It's got a lot of work to actually change the delivery system. And some of these changes are for people in existing public programs, but some of them are also some new things. So just to give you like a very vague, very broad sense of some of the things that are going on, I'll talk about a couple of them in more detail. This new Office of the Duals, which is trying to coordinate care between Medicaid and Medicare, that's a population that includes a lot of people with serious and persistent mental illnesses, especially older people in their 50s and 60s with serious and persistent mental illnesses. And there are efforts in various states to take advantage of these new opportunities and design new programs. New home and community-based services options under 1959I waivers, and the Medicare Shared Savings Program, which you've probably ever heard about, accountable care organizations. Has everybody heard about accountable care organizations? Mm-hmm. Efforts to try and bring providers together to provide people and hold them accountable for outcomes for Medicare beneficiaries. I'll be back with that in a moment. In terms of mental health, probably the most important direct effort is the Medicaid Health Home demo, for which people with serious and persistent mental illness are eligible. And it provides funding for care management and social support referrals. Care coordination in New York is one of the places that's actually taken up this demo. So linkages to community-based supports are part of this effort, and hopefully it will continue. And actually, the interest in mental health, and I think a very promising sort of signal for the future, is that one of the other delivery system reforms in the law was this creation of this thing called the Innovation Center, which could put out grants for other innovations that people came up with. And they did this thing called the Innovation Challenges. They just said, anybody's got a great idea, send it in. And they got thousands and thousands of applications, and they funded 100 challenges. And what's really interesting, if you look through them, is quite a number of the challenge grants really focused on people with serious and persistent mental illness. There is a real feeling in the delivery system that this is a population where there are opportunities to really improve the quality of care in much better ways. So I think that's all good. But I can't be all about good. I think there are a bunch of challenges going ahead that I just thought I'd flag to all of you in terms of ways that you might think about what to look for as we take a kind of exceptionalist look at mainstream policy. So mainstream changes are really beneficial, but they also can lead to problems because of the exceptional nature of mental health disorders. So we know, for example, that people with serious and persistent mental illness, because of the nature of their disorders, are particularly in need of social supports that wrap around their mental health problems, mental health services. So it's not enough to give people clinical services, you have to be giving them social services as well. Medicaid, under the 1915I waiver option, you can actually, if you're a state and you're innovative, you can do some interesting things. You can provide supported employment under Medicaid, under the 1915 high option. Many states don't do this. So you have very narrow Medicaid programs that only provide people with clinical services. And many services that state mental health agencies have provided in the past may disappear as the funding moves from state mental health agencies into the Medicaid program. And that's, I think, a real danger. I'll come back to that in a minute. At the same time, as all of that is happening and we are moving the money for people with mental health out of the state agencies that have focused on this more holistic view, you actually have this rise in SSI and a rise in the number of people with mental disorders in SSI that is leading Congress and people, all sorts of people, to look at these programs and say, are we giving too much income support to people with disabilities? And the most vulnerable population, as we look at that, are people with mental illnesses. We already saw it once when we tried to cut back on SSDI in the 80s. So I think the rising number of people with SSI, which actually I think, stepping aside from mainstream and exceptionalist policy, is a huge challenge to all of us. We have effective treatments, we have more people in treatment, we're delivering better care, and more people report functional impairment because of mental illnesses. Something's wrong with that story that we need to puzzle out. But I would like for it to be us who puzzle it out, and not the people who just want to cut the cost of the program. So I think that's a real concern going forward. Second concern has to do with the delivery system reforms. So they're great, and we're doing a lot of good things, but we have very few quality metrics for measuring performance in mental health. The quality metrics we have tend to be things like, did you have a visit within 7 days after a hospitalization? Or did you screen somebody for depression? So one problem with those measures is you don't need a high school diploma to get those measures, right? Did you screen somebody for depression? You can give somebody an iPad in the office and you've done it. Did somebody get a visit? All you did is book them for a visit. You have no idea what happened at the visit, whether it was a useful visit, whether the person who did the visit did anything for them. We have ACOs, health plans, Medicaid programs can look like they're providing lots and lots of mental health care. They can meet all these standards, and they can do a lousy job of providing anybody with effective treatment. So moving to performance-based payment is a wonderful thing, but it is a terrible risk to a sector where we are so poor at measuring performance. And we are very poor. We've gotten better at measuring process, but we really are not good at measuring performance as it really counts. And the third challenge, I think, is really the sources of financing. We're seeing this big increase in Medicaid and a big reduction in state money, and that raises a bunch of challenges. The biggest challenges, I think, right now from an operational perspective, are for substance use programs, which have historically been very heavily dependent on state funding and really do not know how to deal with an insurance model at all. They've been kind of cut out of an insurance model. But there is a much broader concern, which is the state used to be the guardian of people with mental health problems, and now no one is the guardian. Medicaid just makes them like everybody else. So if there isn't going to be an advocacy effort in terms of state funding, where that advocacy effort is not going to be tied to money, who is going to take care of people with serious mental illness in a broader sense? So directions for research, because I know there's a lot of doctoral students here. I think my number one direction for research is performance measures for mental health, especially measures that are focused on functioning. We have done a lousy job of it. I actually think it's a place where social work could be really important, because I think the way you want to think about mental health measures is how are people able to live their lives, not are their symptoms alleviated. Not the kinds of measures that you test a drug on, but the kind of measures that matter to people. And that's the way the social work has looked at this problem, which is much more holistic. Governance strategies that recognize the dangers of Medicaidization, as Hal Golden calls it, and more social supports, and really making sure that we have the funds available for supported housing and supported employment and all the other things that allow people with serious and persistent mental illness to thrive in the community, because medication alone isn't going to do it. So let me stop there. Thank you.
Questions, and here they come.
I'm curious to know if ACA takes into account in any way the idea of preventive care and mental health. So much of this seems like addressing issues after they arise as opposed to doing anything to prevent them in the first case.
So the preventive services in these, so there is a provision in the law. One of those essential health benefits is preventive services. But the preventive services are the preventive services that have been judged as A or B by the United States Preventive Services Task Force. Once we have a mental health prevention service that is judged A or B by the USPSTF, it would be covered by that. Right now, we are nowhere near that. And in fact, the way that we think about mental health prevention is not really in that kind of clinical way. I think mostly, we don't think about the doctor giving you a preventive depression vaccine. So there is a big gap between where preventive services are and where mental health preventive services could be. The only place where that might show up is that we are moving to more risk-based financing arrangements. And if you really thought that you could prevent mental health in a way that would save you money, which I am extremely dubious of, just because you have to treat a lot of people for a long time before you can actually have a clinical effective prevention, you're not going to see it. Yeah.
I'm just curious about your thoughts about this increase in SSI recipients, particularly since people with substance abuse disorders were sort of purged from SSI eligibility in the 90s.
So,
What do you think's going on?
well, they were purged, it was in the 80s, so some of that may have come back a little bit, but that's probably not most of it. So the research on it suggests that what you're seeing is increases, that a lot of it has to do with the labor market. So a lot of it has to do with the labor market for kind of low-wage workers and what's available, what options are available to them. And to a very small extent, how the labor market has changed over time. That is, we move to a knowledge-based economy. There are kinds of jobs that you could have done while you were an antisocial, depressed person that maybe you can't really hold if you have to be on the telephone with people all the time. That's part of your job. So some of it may be that. The rise has been basically in depression. It's not in, I mean, schizophrenia prevalence hasn't changed, and people with schizophrenia go on when they're 25. That's not really what's going on here. A lot of it has been in depression and in musculoskeletal conditions. If you map where the, this is way too much answer, but if you map where the growth has been and you map, it turns out to be, there's kind of this swath of states around Kentucky, Tennessee, West Virginia. I don't know. They are troublesome states on a bunch of measures. Very high rates of use of opioids, heroin gateway drugs. Very high rates of use of opioids. Also very high rates of ADHD treatment for kids. Just a lot of sort of psychotropic medication floating in the water. And they're also the places that you see these big increases. Now, opioids could be showing up as musculoskeletal problems or as substance use issues. So,
Diabetes as well?
no, mostly it's all in musculoskeletal. Yeah. Yes.
Hi, I was wondering, does the ACA take into account the whole capping of benefits for mental health care visits? Like,
So that's parity. Parity says you can't cap as.
so, but it doesn't matter if it's biologically based illness or not?
No, that distinction is gone.
It's gone, okay.
So you have to have parity. Now, you can do utilization management, but you have to do it in a way that is consistent with the way you do utilization management for other conditions. And there's a lot of research going on what that means exactly, but it seems to be kind of sort of happening. And not beautifully. There are problems, but there are problems that are, how should I say it? It's like once you build a structure that allows you to deal with the problems, there's going to be a lot of work to get to the problems, but at least it's there. Yeah.
So I've been trying to understand these 1915 regulations, because I think that's where social work really could play a real creative, innovative role. Do states get to work those plans out by individual states?
Yep.
Or they do?
They're waiver requests, so you can get a waiver to do certain kinds of things, yes. And by state. But, you know, one of the things that states do is if one state has done something, it's easier to follow to sort of put in a waiver for the same kind of thing. So there's some effort in mental health advocacy to kind of develop models of things that can go from state to state.
Yes, just piggybacking on Mary's question, she said you were concerned that some states will remain pretty narrow in terms of what they reimburse through Medicaid, but isn't there an incentive to take advantage of these 1950?
Well, remember that right now-
They're going to be cost saving, yeah?
Well, remember right now, we're in a world where half the states have decided not even to take the Medicaid expansion. So incentive is not enough. It's, you know, to be fair, it's challenging to write a 1950 waiver application. States that don't have sort of boots on the ground to do that are going to find it difficult. It's not, it's supposed to look cost saving when you give it to Medicaid so that they agree to the waiver. Whether it's actually cost saving at the end of the day is an open question, and in many cases it probably is not. It certainly exposes you to dealing with a whole new set of providers and thinking about a whole new set of realities. It's one thing if you're in New York State and you have lots of resources at hand and money, lots of money on the table, but if you're running a really skimpy, lousy Medicaid program, this is going to be it's going to be a tough challenge to get programs in place. Yeah.
Do you think the ACA will realize, I guess, its goal of sort of addressing where the Heckler report left off in terms of addressing health disparities and that sort of thing?
So I have to talk about this Wednesday. I haven't prepared my notes for Wednesday. So there are many disparities that the ACA will address. The disparity in insurance coverage can be addressed because now there is insurance coverage that is available to lower income people. There are some workforce efforts that will help. The ACA and the entire world of social policy that we can come up with, and it's too bad Dalton has already left because he's the world's expert on this, but you know, is not going to erase all of the other problems that we have in our society, and I think it's sort of not fair to expect that. I think that what I was trying to, I had a beautiful line at 3 o'clock in the morning about what I was going to say. It's not that the ACA or healthcare reform can erase disparities, but they can erase some of the impact, some of the effective disparities. So it's not that they will make people, it's not that it will make people very much healthier, because insurance doesn't make people very much healthier. It makes them a little bit healthier, it doesn't make them grandly healthier, right? But it will mean that when you're sick, you can go to the doctor, which doesn't mean the doctor's going to cure you, but we don't always expect that when we go to the doctor. The doctor might make you feel better, and that would also be helpful, or give you some sense of what's happening in your life, and that would be good. So, and it's going to keep you from going bankrupt when you go to the doctor, and bankrupt when you go to the hospital. So there's a lot of good stuff that will come. It's probably too much to imagine that what it's going to do is erase the disparities in health that exist. How's that for depressing? It's probably just too much to ask that. It's like I was thinking about it at night. It's like saying, Kim, do you think that sending kids to excellence, if we sent all kids to the same excellent schools, the children of college professors would do as well as the children of uneducated parents? No, like, you know.
But there are disparities that exist for everyone.
Right.
So
What we can do is reduce the effect of those disparities on people, on other aspects of people's lives. We can give people financial protection. We can give people access to care. We can take away the horrible fact that in America, until 3 months ago, you could wake up, your spouse could wake up in the middle of the night and say, I feel terrible, and you'd be thinking to yourself, can we afford to go to the hospital, right? To me, I grew up in Canada, it's just a unbelievable thought. So we can do that. We can't make people healthy just by feeding them. Yeah.
And I feel like, just to comment on that, I feel like by doing that, by improving the access, by allowing people to say, I don't have to worry, I'm not going to go bankrupt, a lot of diagnosed anxiety might be reduced.
Yeah, well, that's what the Medicaid, that's what the Oregon result says, right? If you know you can go to the doctor I mean, it's like, has anyone ever had a toothache that goes away when you walk into the dentist's office? It's a real thing, right? Knowing that somebody is going to take care of you is pretty central to human existence, right? Yeah.
Just a comment and then a question. So the comment is that I think what you're saying, and sort of language we would use like in our social policy classes and our oppression and discrimination classes, is that we're removing a structural barrier, right? Just by access. So in that sense, is that all of what's going to go into differences in health and vulnerability of poor people
Right.
to bad health? No. But that is
It helps.
something important
Right.
and something that can't otherwise be overcome. So
I like that. It's a structural.
Okay, just a rephrasing on that. But my question is, as a School of Social Work, and we've got a couple of HRSA grants that are educational, awards to really retool and redesign education to prepare social workers to be delivering optimal behavioral health care under the Affordable Care Act. And a lot of the focus of both of those grants, and they focus on different populations. One is an older so-called polypharmacy population with a lot of medications and chronic health conditions, and another is people with serious and persistent mental health disabilities. And so both having disparities in co-occurring disorders, but very different populations. And so a lot of the interest of HRSA in funding these awards focuses on trying to improve the quality of integration between primary health care and behavioral health care. And really, the structural piece for that is sort of breaking down the barrier between the different sectors, right? Behavioral health and primary health care. So, given the affordability and the quality goals, or given, the efficiency and the quality goals of the Affordable Care Act, we're working very hard to prepare our students to be comfortable in working in primary health care settings. Their depression screeners and FQHCs and things like that, and to be able to speak up and be assertive in terms of, other healthcare providers, trying to reduce disparities in mental health serving agencies for people with serious the healthcare disparity. So, so we're focusing a lot of on-the-ground service delivery, and how much difference do you think that's going to make in the long run in terms of reaching the goals of the Affordable Care Act and ultimately improving the health of the nation?
So it's pretty clear that if we're going to provide mental health services to people who need them, seriously ill and non-seriously ill, we are not going to do it by relying on the existing delivery system. It doesn't even work right now. Most people are not getting care from psychiatrists or PhD psychologists. That's just not how mental health delivery is working. It's working in primary care offices, and it's working in community health centers, and that's the reality of it. It's the way it's got to be. It's cheaper, but it's also a lot easier for people. People are there already. They've come in for some reason. You've got a captive population. These are all good things. So it seems pretty critical to be able to provide services in those settings, to be able to create that liaison, to be able to provide services to hard-to-treat populations. I mean, this is the way we're going to have to do it. There is no other way. And we're either going to do it well or we're going to do it in a sloppy way, so I'm glad you're teaching people to do it well. I think the challenge is to come up with models that go beyond the number of students that you can teach here. Because even though we
let alone fund as a result of those steps.
let alone fund as a result of those, right? So how are we going to do that? How are we going to take this to scale? And I think one of the lessons of this sort of mainstream exceptionalist thing, one of the tensions is we are very good at figuring out how to do this. We have these beautiful programs. And then, Medicaid comes in and says everybody's got it, and everyone's like flailing around, and they just do whatever they can with what resources are handy to them. So how are we going to make this, how are we going to take it to scale? And I guess that would be the big question.
But is there going to require major curriculum revisions in medicine, and nursing, and social, and the healthcare providers are going to have to look at?
So, we could do curriculum revision, but curriculum revision, the reality is, so from what I hear from The experience of medical school is that you wind up in a hospital with a very sick person, and everything that anybody taught you in all your classes about collaboration and health policy and all of that flies out the window compared to what you need to do today on the floor. So, do we need to train people in teams? Yes. But
But I think you need to train people about what other people can bring to this.
what other people can bring to the team, totally. We have, the challenge of doing it in medical schools is, I think, unbelievably huge.
Well, I think medical education, I think of like, it's like a pillow, and it's full. And if you're gonna push something in, something's gonna pop out at the other end of the pillow. So I'm not talking about it in that way, but I'm talking about it in terms of educating the various healthcare providers as to what the social worker can bring to that situation that you don't have to worry about it.
Right.
And I think,
And the way that will happen, I think, is probably through practice. So what will happen is that people will see it, and they will benefit from it, and they will like it, and they will say, I couldn't practice my clinic without social workers. And once that happens, you're golden. It's the same problem as with electronic health records. You can force people to buy electronic health records. If they don't find them useful, it's useless. And if they do find them useful, then you'll actually see doctors who say, I wouldn't practice somewhere without an electronic. I don't want to conflate social workers with electronic health records, but from a doctor's perspective, they're probably the same thing.
Other comments, questions?
I just have one comment that kind of gets to the unintended consequences of delivery system reform.
Yes.
So what we're seeing out there is that we've got a bunch of people who are used to solo practitioner models, and now they suddenly have to engage in collaborative care. And we've got at least 50% of the seriously mentally ill people out there who have comorbid medical conditions.
Right.
And what's driving the costs are really the comorbid medical conditions, more so than the serious
Yep.
mental illness. And so there's an awful lot of work, I think, being done around secondary and tertiary preventive care that hadn't been done before, and focusing a lot more attention in those areas. So I'm wondering whether or not there is some way of systematically approaching this notion of this new service delivery model that we have out there, because we've got a huge workforce that has no exposure to this whatsoever. And we need to be able to expose them to this so that they can engage in it successfully and competently.
To deal with the clinical, the medical conditions of, right.
Absolutely.
Right, I mean, we have some models in mental health care, sort of community treatment teams and things like that, where you really have these very well-established models of collaborative care that do stretch across boundaries, and probably have to stretch across even more boundaries now that you think about clinical consequence. They've been hard to take to scale, right? It's
Very hard.
very hard, right? One of the things that's going to happen, I think, so mental health, I was saying to Rebecca beforehand, has been an interesting field because we talk in most of medicine about people, what is it called? Practicing to the limits of your certification, what is it called? To the top of your license, whatever. In mental health, that happens very rapidly. We actually have the shifting, besides the prescribing, you actually see social workers providing care that 30 or 40 years ago, only clinically trained people were providing, and with no deleterious effect, as I keep saying. But with deleterious effects, in fact, on the earnings of psychiatrists. Very deleterious effects.
Not enough positive benefit on the earnings of social workers, however.
Yeah, it's actually, you can actually see I have a slide, you can see everybody converging to social worker salaries. But salary parity. Yeah, so, but down, unfortunately. And, hundreds of thousands of newly trained people, social workers coming into the field. My guess is that medicine is going to see something like this happening. You're going to start seeing the emergence of different professions, physician assistants, nurse practitioners, clinical nursing, expanding in the way that social work did into mental health. And basically, you see it with the minute clinics, you start to see, the world is going to look different.
Oh, absolutely.
So you're on the vanguard again. Did you have a question?
I kind of, but I haven't formed it completely.
Wake up at 3 in the morning, right?
What's your comment?
No, I'm having trouble sorting out the intersection. I was really struck by what you said about insurance can't solve everything, because I think sometimes we tend to think of insurance as medicine, and it's not. It can only
Medicine
do
can't
so
solve
much.
everything either.
Well, very true, very true. But I'm struggling with the intersection of the Affordable Care Act and the quality of service delivery and the outcomes we're looking for that, as you point out, we're not good at measuring. And I just have this thought that part of the problem is we're asking a lot of the wrong questions. And I'm not 100% sure what the right ones are.
That's why you're a doctor.
But the outcomes we're looking for and the way we're trying to look at them are just poorly conceived, it
Yes.
seems, and they're okay. Well,
That's why let me just tell you my little story on this, okay? I actually started off doing a lot of work in child mental health services, and I got pulled into the whole thing about ADHD, and you have this beautiful result from the MTA, from the big clinical randomized clinical trial of mental health, which is if you give kids Ritalin, their ADHD symptoms go away. It's wonderful. Give them lots of Ritalin. You gotta give them a lot of Ritalin. But I asked, what happens to them in school? And it turns out it doesn't do squat. Nothing. All right? Nothing. In fact, there's some evidence that it actually is worse. Not only in the long run, even in the short run, even in the clinical trial itself. Even, while they were going on and on about how it takes kids' symptoms away, it turned out that the measures of how they did in school were 0. So I'm an economist by training, not a mental health person. I never thought about mental health. If a kid doesn't graduate from high school, I don't care whether their ADHD symptoms have gone away. I mean, their life is shot. I'm sorry, I shouldn't say that. Probably many people do a good job without graduating high school. But in today's economy, that's just a terrible thing. If we can't get those kids to graduate from high school, throw the pills out the window. They're not doing any good. And the same thing is true for many of these other conditions. If we're not helping people to actually realize their potential in the world, we're not doing them any good. If people were doing arthroscopic knee surgery on folks and they couldn't walk afterwards, we'd stop doing it. Maybe not. But, and I think social work is a good place to be doing this because medicine and people who work in mental health on the medical side are so focused on the idea that mental health is just another clinical condition and depression is the same as asthma and all this nonsense. Yeah, depression is the same as asthma, but the measures for whether people are better or not are different. The measures for whether people are better or not are, can you hold a job? Can you go home and take care of your kids? Not, can you breathe into a tube? And if I make the outcome, can you breathe into a tube, which is, I give you a Hamilton depression scale. I'm sorry, I'm getting really head out about this, but I give you a scale and you check off 6 boxes instead of 8. It's not relevant. Breathing into a tube has something to do with your ability to walk down the street. So, yeah, we got to work on that.
So just like your ADHD example, the difference between symptom and real functioning.
Yes.
Functional differences, they're vast.
Yeah.
They're very vast.
And we've just given up on it. Yeah.
But I think I just kind of wanted to elaborate, or to see you elaborate more on how this would impact child mental health and behavioral health. Since the service delivery and the diagnoses can be so different, I just,
So I didn't talk about kids because actually the Affordable Care Act doesn't have very much impact on kids. And the reason it doesn't have very much impact on kids is that we already passed SCHIP, and the population of kids, the population at risk of uninsurance among kids is just much, much smaller than it was among adults. So the effect on kids is much smaller. And the delivery system changes are mostly focused on the adult population. This is not altogether a good thing, as I just said. I mean, I don't think we do a great job with kids' mental health. We do a lousy job, but this is not a big change there. Okay?
I think that's about it.
oh, no, yeah.